Yeah. Good morning, everyone. At the outset, I would like to thank Dr. Suresh and the GMCHI department for giving me this opportunity to be here. So I'll be giving a very short presentation as we're already running short of time. So dry eye is something which all of us see in our routine OPD, whether you finally end up doing corneal surgeries or retina surgeries or cataract surgeries, but this is something which you will always encounter. So I'm just here to share some of the difficult cases which you might see and get some insights that how we manage them. So case one, this is a 55-year-old female with a known case of rheumatoid arthritis. So she had a secondary Sjogren syndrome. She presented to us somewhere in January 2023 with the loss of vision in left eye for 1 year. There was a total loss of vision in the right eye 2 years ago. She had developed some presumably a corneal melt secondary to the arthritis and eventually leading to phthisis bulbi and a PL negative status. So the left eye, she had a PL positive, PR accurate, but she had undergone an AMG and a fibrin glue and a therapeutic keratoplasty was done to basically save the eyes elsewhere. So you can see that patient had all the features of rheumatoid arthritis and the right eye was already a phthysical eye. So patient had a failed vascularized graft. She had a severe aqueous deficient dry eye. The tear breakup time invasive was less than 2 seconds. Puncta were already stenosed, both the upper and the lower one. Vision was PL positive and PR accurate. The ultrasound B scan was normal for the posterior segment evaluation. Intraocular pressures were normal. And she was already on oral steroids for the last 2 years for the management of rheumatoid arthritis. So she was started on preservative-free sodium hyaluronate 0.2% every 2 hours in this eye. Cyclosporin drops were started twice a day. Prednisolone was also started to reduce the inflammation of the eye, along with the pressure-lowering agents, which she was already using earlier from the after the therapeutic keratoplasty. So there was a high risk for a regraft failure, especially because of the severe dry eye. But nonetheless, since we had nothing to lose, we went ahead and did a keratoplasty. So she had a single-eyed status. So we sought an rheumatologist opinion also and started her on strong oral immunosuppressants, the tocilizumab and methotrexate. Eventually, she underwent an optical graft on 25th Feb 2023. Post-operatively, she was continued on high-frequency topical steroids and preservative-free lubricants, along with topical cyclosporin and oral immunosuppressants. So eventually, patient was continuously followed up, and at the last follow-up, which was about 18 months from the date of surgery, patient had a vision of 6/12 unaided, and the graft was clear, the IOP was well maintained with the medications. The fluorescein staining score was 2/9. The central epithelium was clear, and the patient was continued on high-frequency topical preservative-free sodium hyaluronate 0.2%, along with topical prednisolone and cyclosporin 0.09% preservative-free. So a combination of potent oral immunosuppressants, both tocilizumab and methotrexate, was continued. And eventually, now the question still remains the long-term survival of the graft in such eyes and how long you can continue the oral immunosuppressants. So it all depends that the patient's liver functions and the blood counts are well maintained, so we can continue for life also. So now coming to another case scenario, this was a 5-year-old child who presented to us with severe dry eyes for the last 18 months. Patient had a history of beta thalassemia major, for which he had undergone a bone marrow transplant 3 years ago. The child had developed a graft versus host disease, which led to a severe dry eye after 3 months of the diagnosing graft versus host disease. The child had developed inability to open the eyes in bright light, and there was a complaint of constant pain and irritation along with blurring of vision. So graft versus host disease is a syndrome which is characterized by the inflammation in different organs, which includes the eyes, and the other organs include the lungs, the liver, so and after the bone marrow transplantation and stem cell transplants. So this patient had an unaided vision of 6/18 on presentation. The eye looked very dry with plenty of mucous strands. The eye opening was poor. The fluorescence score was 7/9 in both eyes, and the tear meniscus height was missing. The Schirmer test scores were about 2 millimeter in both eyes, and the lid margins were mildly inflamed. The fundus examination was normal. So the child was diagnosed to be suffering from severe dry eye secondary to a chronic GVHD, and we started the child on preservative-free CMC eye drops 0.1% 4 to 6 times a day, topical cyclosporin 0.05%, vitamin A, and added tear secretors, which were available earlier, but now they have gone off the shelf. And patient was planned for a temporary punctal occlusion. Finally, patient improved with temporary occlusion, so we eventually put the long-term lacrimal plugs, which were done in 2016. Patient was continued on topical medications with on and off of the topical steroids. And once the ocular surface stabilized, appropriate glasses were given, and the best spectacle vision improved to 6/9 in both the eyes. So last year, patient was given the trial of lifitegrast. So in such eyes which have graft versus host disease, lifitegrast has a very important role. It has now become available in the Indian market, though it is slightly expensive, but yes, the results are very rewarding. So as we started this drop 2 times a day, the patient's eye surface stability became very great, and the patient comfort improved multiple times, and the dry eye status was well under control. So this lifitegrast was given for 4 months. The patient could not afford to continue treatment further, but still the child is being maintained on cyclosporin and the preservative-free drops. The tear breakup time has improved to about 6 seconds, and the fluorescence score has come down to 1/9. So there's a happy child which has been followed over 10 years with an all-out effort to maintain his ocular surface health. So now coming to a third case scenario, which is totally kind of a different scenario. It's a 49-year-old male who presented to us with Algrove syndrome, which was diagnosed at AIIMS New Delhi. The chief complaint was constant discomfort and irritation in both eyes for the last 10 years. He was diagnosed at AIIMS by the neurology department, and his case was also published in the Annals of the Indian Academy of Neurology. So he had a history of using all kind of lubricant drops along with intermittent use of cyclosporin drops and chloroquine phosphate drops along with repamamide. But nothing had helped him over the years, and he came with some hope that I would get some relief from the dry eye problem. So the best corrected vision was 618 and 660 in the right and the left eye. He had some scleral abnormality also. So with pinhole, though the vision improved to 6/9. So Sharma's scores were 3 and 2. Fluorescence score was 1/9. The lid margins showed staining of the meibomian glands. So it's a well-known fact that Algrove or a AAA syndrome has alachremia along with the other abnormalities. So we knew that the patient had a low tear production, but we still scanned for the meibomian glands, and we found out that the glands were not healthy. So we did a LipiFlow for both the eyes. And eventually, patient was started on preservative-free cyclosporin drops along with the CMC 1%. But at 1 month of follow-up, patient was still not feeling good and had not any significant relief. So we did a smart plug for all the 4 canaliculi. He was symptomatically better, but still he felt the need for a more frequent lubrication. The punctal cautery was then finally attempted using a radiofrequency laser, considering that we don't want to waste even a single drop of a tears what is being produced in the eye. And the topical preservative-free lubricants were continued, and patient was kept under close follow-up. So at 6 months of follow-up, fluorescence score, staining score was nil. Tear breakup time had improved to 6 seconds. Patient also had abnormal scleral curvature, so we gave him the scleral contact lenses. So considering the dry eye status, the trial of scleral lenses made more difference to his overall comfort level. So a procedure like as simple as something like a punctal cautery worked so well for this patient, along with the use of scleral lenses, for I think which he had been suffering for the last 10 years. So I think we need to look into the other aspects of the management of dry eye whenever we are looking at such patients. So finally, to conclude, a thorough clinical assessment, including the blood work wherever necessary, whenever you see any severe dry eye patients. Giving a good chair time to your patient is very important when you are seeing a patient with a severe dry eye, and always keep a never give up attitude. So all these would go a long way in helping you to treat even the most refractory dry eye cases. Thank you.